Thank you for being here. I am Serretti, as you heard, has been introduced by our very kind colleagues. And I think you appreciate the location. It's a nice place, historical. Bologna is the oldest university in the world, more than many hundred, almost 1,000 years ago. 1088 was founded. And so we are very proud to be here and very glad to be useful for you. As you have seen, the program is an interesting program. I will have two presentations, this one and the next one. This one will be focused on bipolar disorder with an overview and possible future direction for treatment. I know that you are all clinicians. I am a clinician too, as Professor already introduced me. I'm working on pharmacogenetics and genetics, but I'm a clinician and I'm working also with drugs. And therefore we did some studies. We worked about treatment of bipolar disorder. It is quite difficult, as we will discuss later. And then we will discuss about the new possible treatments in depression. The use of antipsychotics in depression, something that is not usually very common, but we will discuss this aspect also. And then we will have other presentations, as you heard, from Professor Benedetti, a wonderful presentation about inflammation that, as you heard, I understood from Turkish, is the plenary of the CINP meeting, so it's a very relevant presentation. And then you will have your German presentation here. So I think the program is quite large and useful. Let's start from the first point, bipolar disorder. Well, I understand that all of you are treating bipolar patients. They are difficult, very difficult to treat, because they are unstable, depression, mania, treatment, tolerabilities. So, for at least for me, it's a big challenge to treat bipolar patients. Let's try to see some points that can improve this work from us. So, we will focus on bipolar treatment and focusing on different phases to see what's new and which are the possible improvements that we can have in our treatment. So let's start from a very old paper, more than 20 years ago. We did this paper where we saw a very common thing, but that has never been clarified before. So what's going on with bipolar disorder and depression? The problem is if you don't do nothing or if you don't do enough, bipolar disorder gets worse during time. So just counting the time from one episode to another, you see that the first episode usually is 5 years from the first episode. Bipolar disorder, like mania, 5 years, and then maybe depression. But the interval goes down to 3 years, 2 years, 1 year, and probably even less than 1 year. So this our study of more than 20 years ago makes clear a very important point. We have to treat bipolar patients. If we don't treat them in a proper way, the natural course of illness is not a favorable course. Number of episodes increase, severity of episodes increase, and they are even more difficult to treat because this is not part of this presentation, but you will hear from the next one, from Benedetti. The brain, the more episodes the patients have, the more the brain is affected in a functional and anatomical way. So this is why it's important to keep our patients well as long as possible. So bipolar disorder alone is a problem. If undertreated is a problem, we have to do something. And this is to make clear what's happening in the bipolar disorder, subclinical changes, and then the first episode, and then other episodes. And this usually, with time, gets usually a little bit worse. This is why we have to focus very well on the treatment. And this is another point that we saw a few years ago. Not all bipolar disorders are equal. For example, focusing on, this was mixed bipolar disorder, mixed depression. Focusing on mixed depression, we see that the outcome, and this is about 1 year of follow-up, the outcome for mixed depression is much more difficult. It's difficult to keep them stable. They keep some depressive or irritability or manic symptomatology. So not all bipolar disorders are equal. And this introduces one point that I will keep during my presentation, the personalization of the treatment. We cannot say bipolar disorder equal lithium, bipolar disorder equal valproate, that's it. No, it's much more complicated. This is just one of the possible differences. Bipolar mixed has a worse outcome. Okay, first point of my presentation was to say bipolar disorder is indeed a problem, is severe, we have to do something. And this is a very nice list of what we have to do. This is taken by the Barcelona group led by Edward Vieta, that you probably know. In my opinion, is probably the best expert worldwide about bipolar disorder. And he made very clear the points that what we should do when we treat bipolar patients. We have to do simple, but we have to do all of these things. Safety, obviously. Treat the symptomatology. Treat psychotic aspects. Avoid cycling, and we will discuss this point of avoiding cycling. That is very important in terms of antidepressants, yes and no, we will discuss this later. Suicidal behavior, we have to take care of it, reduce the frequency of the episodes, and treat subthreshold symptoms. This is something that is also usually not very considered. Well, the main episode is over, everybody's happy. No, we have to check for subthreshold episodes, because sometimes you have some anxiety remaining, some anhedonia, some insomnia, so you have to check for subthreshold symptoms, because subthreshold symptoms are very dangerous and can lead to relapses. Check comorbidities, of course, we have to check all medical aspects there, caregivers, information, psychoeducation, and to rehabilitate the patient as much as possible. These are the points that we should follow when we are treating those patients, the so-called decade. And if you want to see another point of information, I suggest you this very nice and well done guidelines. We are full of guidelines. We will discuss some of them during the presentation. These are the New Zealand guidelines, are very nice, because they are also somehow graphical presented. But what's more interesting is the content. It's New Zealand, very recent New Zealand guidelines. Underline the complexity of bipolar disorder treatment. Today we are talking about pharmacological treatment, of course. Pharmacological treatment is the most important in bipolar disorder, but we should not forget the other treatments. So, for example, in many patients, we have to focus, as an example, on sleep. I've seen many patients in manic state that can improve just by adjusting sleep. You know that sleep deprivation gives a worsening of mania. So, mild mania, if you manage sleep, the patient sleeps 8 hours, 7 hours, 9 hours. This way, you can also avoid the use of a more strong treatment for mania. There was a paper that we did many years ago in Milan, and Benedetti was the lead author, with a nice idea, but difficult to implement. For example, you know that sleep deprivation, if you don't sleep, is an antidepressant effect. And so we thought, why don't we make the manic patient stay in the dark as much as possible? So not light therapy, sleep deprivation, the opposite, dark therapy. And so we did this very difficult to do study that is published in Journal of Affective Disorder. We kept manic patient in dark room for 12 hours a day without much treatment. Well, the dark therapy was much more effective than control. So, of course, I understand that this is difficult to implement. We cannot keep patients 12 hours in the dark. But, just to give you an idea that dark treatment or sleep treatment alone could be already a good treatment for many. And then physical and diet aspects, but not only. For example, physical for depression is very useful. You are aware that physical activity is antidepressant, more or less like antidepressants. So we should always use this when possible. And all the other aspects like psychoeducation and support and avoid, of course, substances that can alter our patient status and so on. And these are very nice guidelines. But let's go now to the focus of this presentation. Okay, bipolar disorder is severe. Okay, we have to do everything around the patient in terms of psychoeducation and physical activities, sleeping and so on. Okay, everything is perfect. But we have to focus on treatments. Treatments. I suggest that this is not very big to see in this screen, but this is on a bipolar disorder journal, always by Edward Vieta Group, a very recent review that I suggest you strongly because I think, in my opinion, it is one of the most clear flow of treatment. Even better than the CANMAT guidelines I will show you later, and even better than the Mosley guidelines that also I consider very useful. This review on bipolar disorder is very clear because it's very clear also graphically. So let's start from what we do at the beginning. Well, first level in almost all guidelines is lithium quetiapine. No, or not together. Lithium is by far the most effective treatment, obviously. There are no doubts about that. We will discuss later, there are some limitations, but no problem at all. Quetiapine also is an effective stabilization treatment, but for depression and depression. Then starts the first personalization issue. If the patient is more on the manic polarity, you know that bipolar sometimes are more manic or more depressive, depends on the clinical picture. If the patients are more on the mania side, more manic, then they should have to combine with aripiprazole. You see, this is a stepwise. Is aripiprazole good for everybody? No, of course. But for those patients that on lithium or on quetiapine go a little bit on mania as well, you can add aripiprazole. And aripiprazole, you know, blocking dopamine D2 receptor, but not completely. 30% is still active, so stabilizing the dopamine transmission. stabilizes the spikes of the manic state. And this is the optimal treatment as a first step. But we all know that not always works. And then we have to do something more for patients who do not respond to this kind of first time. What? Then we have to personalize based on what we see. Is the patient not stable because he's more depressed or because he's more manic? And then we use some options. We can also combine the stabilization. Stabilizer usually is one, but if the patient is not stable, we should use two. We can go up to three sometimes, mood stabilizer together. Lithium, for example, quetiapine, sometimes with valproate, not very common, but for very difficult patients, sometimes is needed. And then something new appears here, lamotrigine. Lamotrigine is not new, but as you know, lamotrigine is very useful because lamotrigine is giving a little bit of energy. Of course, we have to be very careful, lamotrigine with valproate for risk of skin interaction, but it's a good option. You can also use the long-acting antidepressant if you have more pain. Or you can use the dome and long-acting dome. But paliperidone, be careful, because paliperidone is not partial agonist like aripiprazole, it's complete. So you risk the presogenic effect. So I suggest you to use paliperidone very carefully and even more carefully long-acting because you risk the switch in the pressure. Usually these first two steps work for 70–80% of bipolars, but sometimes they still are not stable, they still don't respond. And then we have to do something more. For example, combining, as I told you, more than one mood stabilizer, and then try to do any kind of combination based on what we see. Is the patient, for example, not sleeping well with lithium and valproate? We can add olanzapine, that is more sleep-inducing. Or is the patient maybe active despite lithium and valproate, then we can go to paliperidone or risperidone. And then this third step, as you see, is the more complex, because here we have to do combinations that are based on what we see in the patient. Not very easy, of course, but this is what we have to do. Very few patients are not stabilized despite all our effort with the three stages, and then we have to go to ECT sometime. But ECT is useful, but of course it's difficult to do maintenance with ECT. I knew that some people used to do this maintenance with ECT every month, but it's not very practical, of course. But in any case, psychoeducation, general measures, and stage 2 or 3 usually are sufficient. I think 1 out of 1,000 will not stabilize with this algorithm. I stayed a little bit slowly on this algorithm because in my opinion is the most relevant and important to have an idea. But let's discuss some other options. Is the only option, the one that we have seen? Yes and no, because there are indeed other options. To see which are the options that we have, the review by Vieta is useful, but I suggest you to go to the CANMAT guidelines. CANMAT are the Canadian group. They did very good guidelines with this balloon style. That means full is very recommended, and half is not recommended, and 1/4 is recommended, so and so. And they are very useful because this way you can see for each specific aspect. Let's focus on mania here. We have some drugs that are clearly recommended. So with mania, we can work within this drugs in a quite clear way. Lithium, Psychiatry, Bipolar, Psychiatry. We didn't mention Psychiatry. Psychiatry also is indication for mania, of course, quite delicate. Aripiprazole, paliperidol, risperidol, and cariprazine. We will discuss cariprazine in the next talk. So let's not talk about it. These are the most useful compounds in mania. But mania is not so difficult to treat. Which of them is best? My friends from Verona and the UK, they usually do this kind of very large meta-analysis trying to see which are the best treatments available for everything, in this case for mania. And they show that more or less, in terms of efficacy, all the antipsychotics are similar for mania, except gabapentin, of course, or pyramid for mania is not appropriate. All the other are very similar, and it makes sense. So it's not on the efficacy of the antipsychotics on mania that we have to work. We have to work on the specificity of which antipsychotic to use. And in this graph, let me be very clear that more or less the most famous one, Psychiatry, olanzapine, and risperidol, are in a good position in terms of efficacy and acceptability. Haloperidol, of course, is the most effective in terms of mania. Haloperidol is blocking dopamine D2 completely. So the effect on mania is dramatic, but at the expense of tolerability. Haloperidol is not a light drug. Haloperidol is to be given very carefully. And all the other are a little bit less effective, but not so much. Haloperidol. I know that haloperidol is quite common and is used everywhere for mania. One suggestion. Okay, let's use haloperidol for severe mania. For sure it's effective, meta-analysis is very clear and clinical experience as well. But haloperidol compared to other antipsychotics is quite toxic. So let's be careful. For example, in this study looking at the mortality after antipsychotic exposure, we see that the usual one like Psychiatry, olanzapine, and risperidol are here, but haloperidol is here. Which means that there is 4% risk of mortality more. And there are indeed studies, but you see also in clinical practice, haloperidol is giving more extrapyramidal side effects and things. So it's a good, effective drug, but I would suggest to use it for a short time and then shift to the usual ones, second generation or atypicals. And this is haloperidol. But also the new one may give indeed some issue. And this leads to the next point. When we treat bipolar disorder, we must be careful about the tolerability. You know, we as doctors, as they said more than 2,000 years ago, first we should do no harm, and then we should do some good. So we must be very careful about the tolerability of our compounds. Antipsychotics are always antipsychotics, with extrapyramidal side effects, risk of tardive dyskinesia, metabolic side effects. So we have to be very careful in using antipsychotics as much as possible. Then what we do in the other phase of bipolar disorder, depression. The depression in bipolar disorder is probably a little bit different than the depression in the major depression. Some people say that it is more quick, more rapid onset, more frequent, more severe, usually shorter, and usually with reverse the symptoms, the atypical depression. In my opinion and my personal experience, I agree with this. bipolar depression usually is more, yes, shorter and more severe, more physical, I would say, yes, some more frequently also atypical depression, but not only. I see sometimes more weight loss, yes, more physical. Indeed, we did a study a few years ago in very large samples, and we have seen and we confirmed these differences in bipolar versus unipolar depression, but not only the ones that we have seen from general literature, we saw something even more specific. For example, we saw that usually unipolar subjects have a little bit more anxiety compared to bipolar, and this also makes sense compared to my personal experience. And this also gives you indication about the different treatment of both. Insomnia, more atypical, as we said before, in bipolar, in unipolar, more mixed, of course, in bipolar, and more psychotic usually in bipolar. So bipolar depression is not exactly like unipolar depression. We have to keep in mind that there are differences, also in the treatment. And what are the famous candidates for treatment of bipolar depression? Well, the full lot is only for quetiapine, flurazepam, and SSRI plus propofol. All the other are less. Let's discuss it a bit. Quetiapine, of course, is useful for bipolar depression. Nobody doubts this, I agree. In the range of 150 to 300, okay, but we have to be careful about metabolic aspects and somnolence. It could be good in some patients, but not enough. Lorazepam, we will discuss in the afternoon. In the next presentation, it's an option with pros and cons as well, which we have to say. Lithium, not very effective in acute depression, lamotrigine in EDS, ECT, there are some suggestions. This is one of our studies. We try to see if quetiapine was indeed useful in bipolar depression, and we have seen that indeed not only quetiapine is useful in bipolar depression, but it's weak. The originality of this study that we saw the outcome after 3 days, not the usual 1 week. And we were surprised to see that we had a 25% of improvement also after 3 days, 4 days. And the improvement continued, particularly for 600. 600 is a little bit a lot for quetiapine as an antidepressant. So it depends on the patient. I would suggest start with 200, go to 300 and see how it works. 600 maybe a little bit too much. And of course, anxiety improves as well rather than depression. So quetiapine is an option. Let's talk for the last part of the presentation of another very difficult issue, antidepressant. Antidepressants in bipolar disorder is one of the topics that always has been discussed so much. I remember since 20, 30 years ago, everybody was saying, oh, no antidepressant at all in bipolar. Other people were suggesting, yes, antidepressant in bipolar. So I think it's important that we have very clear information about to do with antidepressants in bipolar. First point, the risk of a switch. I know a lot of colleagues from us that say, oh no, antidepressants are very dangerous, they can switch the patient to mania. We did a study on the American databases with our Japanese colleagues. And in a very large number of patients followed for a long time, we saw that the risk of switch in reality is very low. very low and limited to some categories of patients. Specifically, the younger patients with rapid cycling, with very severe mania, suicidal intent, and of course, stimulant use. So, first concept, switch is not such a big danger as we should usually be afraid of. But I suggest you to read this paper. That was a very, very big paper that we did some years ago with the Vieta group organizing with Isabella and me and other people. We did something different this time than the usual guidelines. Because this question about what we should do with antidepressants in bipolar disorder, it's very confusing. If you go also on the CANMAT or in the Maudsley guidelines, or in American guidelines, they are not clear. They say, well, you may use it, but be careful. What does it mean? You don't know what to do. And so we had this idea of doing a paper where we expressed the expert opinion. What 60 experts on bipolar disorder in the world were thinking about how to use antidepressants in bipolar disorder, and of course published in the American Journal of Psychiatry. Few concepts, simple but very clear, that came out from this discussion that we had. First, antidepressants should be used when there is a history of previous positive response to antidepressants. Almost everybody is agreed. And this is a very clear concept. You ask the patient, did you ever had benefit in the past when you had depression from sertraline, from something? Yes, no, maybe, don't remember. Okay, this information is very useful. Second, antidepressants should be avoided for an acute bipolar 1 or 2 depressive episodes when you have a clinical picture that is suggesting you some risks, like mixed episode or rapid cycling in the past. And this suggests the risk of switch. So first two concepts very clear. Antidepressant, yes, if it was useful. No, if you have a mixed clinical picture with rapid cycling. Makes sense? 3, this is another very important point. Should we keep the antidepressant for a long time or forever together with lithium, diapine, or whatever? Well, the answer from the expert is yes, if we take out the antidepressant, the patient goes into depression. So if we have lithium, not sufficient. Lithium plus antidepressants works well. Take away antidepressants, the patient goes into depression, then you should take the antidepressant back. And this is something that happens sometimes. I remember I had many patients with mood stabilizer treatment. Lamotrigine was probably not working, antipsychotics maybe to give some side effects, and then I put some, depending on the case, fluvoxamine or sertraline together with lithium, and it worked. Sixth point, to be careful about the signs of switch. Mania doesn't come in 1 hour, comes in 2-3 days, minimum. So if you monitor the sleep of the patient, you realize in advance what's happening. Now we have, I don't know if you use it with your patients, we are starting to use here the wearable devices like watches or bands that communicate with you in your computer what's happening, and so you can see the patient maybe is not sleeping well, and an automatic alert, You call him or her, you say, oh, I see that you are not sleeping well for 2 nights. Maybe it's a sign of mania. We should do something. And in the future, this will be more and more common. History of mania, of course, and then mood instability are obvious. And what about antidepressants alone? Antidepressants alone are very, very dangerous. Very dangerous. We are 91% of us agree that antidepressant monotherapy should be avoided in bipolar disorder. You could say, well, obvious, nobody's suggesting antidepressant monotherapy in bipolar disorder. I can tell you that I've seen many situations where bipolar were kept with antidepressant monotherapy alone. This is not supported by any evidence. So we suggest that we should not use antidepressant alone at all. Mixed states are very difficult to treat. We should definitely avoid antidepressants in mixed states because they can worsen the situation, and we are all agreeing on this point. Some people is suggesting 90% that sometimes we use also in mixed states. In my opinion, in mixed states are not, I voted this way. So I don't think in mixed states it's important, it's useful to use antidepressants. And the last point of this opinion paper is that tricyclics and serotonin and noradrenaline drugs should be avoided as much as possible. Because you know that the risk of switch is higher with tricyclics and venlafaxine. So use these drugs only if very, very needed, because the risk of switch is very high. So concluding the depression part, and we are going to the end of this presentation. Depression is a big challenge in bipolar disorder, but we have some news. Antidepressants are less good than we believe, because they are not extremely useful in bipolar depression, but they are also less bad than we believe. They are not so dangerous. They are just marginal in the treatment of bipolar disorder. They are not evil, they are not the solution, they are just marginal. A typical antipsychotic is interesting, depending on profile, aripiprazole, lorazepam, olanzapine, quetiapine, depending on the profile of the patient. Amorphine would be useful, and the key is to personalize treatment. The last point about personalization of treatment. I would like to show you this other paper from ours that was done by Alessandra, and it is focusing on a very interesting point. What people do in a very good center. This is again the center of Barcelona that I'm collaborating with, Edward Vita, the center. They are very good because they are doing, I think, probably one of the best worldwide clinical activities with bipolar patients. They have a large outpatient unit, inpatient unit. And so this paper is what clinicians do. And the answer is very interesting because clinicians try to tailor, try to individualize the treatment on the basis of the patient. In the so-called different packages, what are the packages? Are combinations of treatment, mood stabilizer, antipsychotics, in a peculiar way for every patient. So you see that there are large uses of typical more than 1/3 of stabilizers and also antidepressants, quite large use. But this use is divided in the kind of patients. In a factor analysis, we saw that there are basically 3 types of bipolar patients, but there are more, of course, but to summarize. The bipolar are mainly manic, and so they need the anti-manic stabilization techniques, mood stabilizer plus antipsychotic, and they are bipolar with predominant depression polarity, and they have the so-called depressant stabilization package, mood stabilizer, antidepressant, for example, or specific antidepressant. And then we have the so-called antibipolar 2 package, the one that is on a small mania or hypomania, and they need a different treatment. And so it was very interesting to see in this paper how clinicians indeed try to do their best to personalize and tailor treatment using all the compounds that we have. Few words on long-term treatment, not much to say. It's what we already discussed in the previous part. We should focus on what is more effective and tolerated by the patients and the cost, of course. Maintenance usually is more tedious. The first line is alkanal, lithium, quetiapine, valproate, amotrypsine, olanzapine. These are the most used. One word about lithium. In this old paper that I did when I was in Milan in San Raffaele, where Benedetti is coming from, we saw a very interesting point, that lithium in the blood of patients changes during the year. It's not surprising. In summer, like now, hot, sweating, dehydration, and lithium concentration increases. So in summer, we have a peak of lithium concentration. And in autumn, there is a reduction of lithium in the blood of our patients. So we must be very careful about this, because in summer, we risk intoxication. And in autumn, we risk relapse, because autumn is already a period of relapse, and if you combine also the decreased lithium plasma level, the risk of relapse is much higher. So do consider this with frequent lithium monitoring in our patients. And another point of lithium, I found this paper that is quite an old paper, but it's very useful. Don't forget that lithium is not so friendly with the body of our patients. And for example, thyroid or kidney suffer from lithium in the long run. What I have seen in this very interesting and I think unique paper and literature, after a long follow-up, the creatinine kidney function is worsening after 15, 20 years of lithium. Of course, creatinine is worsening also for aging, obviously, but it's worsening more. And what is surprising, that even if you stop lithium, creatinine doesn't worsen more, but it's not reversing, of course, because age is going on. So what's the take-home message here? Let's be careful. Lithium is very effective, of course, but it's not the perfect drug, of course. Rather than acute toxicity, we have long-term toxicity that is not trivial. So let's consider this. And talking about side effects, in this other paper, you don't need to read them all. Just the concept here is that the side effects are different from the compounds that we use. In this paper, we saw, for example, that if you use mood stabilizers, you have less somnolence than if you use antipsychotics, of course. Less extrapyramidal side effects, but you can have this long-term treatment effect. And you can have, for example, a little bit and sedation and more concentration. So, depending on what you want, you have different profiles in terms of mood stabilizer. Final concept I wanted to give you is this is quite new. I don't know if in your country you have this 3-month long-acting Trevita, haliperidone. We just published recently this paper, and there are also a couple of other reports and literature. Use, when possible, long-acting, when possible, and be careful, remember, because there are also contraindications I will discuss before. Because it seems that long-acting treatment, you can use much lower doses compared to oral treatment. This makes sense, because oral treatment, increase after 1 or 2 hours, and then decrease, and then you give again. So you have a change in the pharmacodynamic effect in the brain. With the depot, the effect is stable, and so in the brain, the effect is stable. So you need less drug. This in theory, but also in practice. I think we were the first in the world to demonstrate that patients that were stable with oral paliperidone and then stable with 1 month paliperidone, we switched them to 3 month paliperidone with lower doses. This here is the minimum effective plasma level compared in the general literature. So all our patients were below the minimum threshold of plasma level of paliperidone. So they were underdosed in theory. But after 9 months of treatment, they still were well. So our conclusion from this observation is that with the 3 month long-acting, also for 1 month, but 3 months even more, you can stay lower in terms of doses. So if the patient was at 9 milligram per ounce per day, 333 of paliperidone, you can go to the equivalent of 4 or 3 or even 2 with the long-acting, and it's effective as well because it's more stable. So the pharmacodynamic effect in the brain is more stable, and this is something that would be very useful for practical activity. Okay, we are in time. The last concept. Mixed episodes are very difficult. Here, suggestions as you see are very scarce. Asenapine and aripiprazole are first-line treatment for mixed. That makes sense because aripiprazole is stabilizing the dopamine transmission, so and asenapine as well. And also olanzapine plus lithium. And there are no many other treatments. So mixed episodes are quite difficult, honestly. And also the modes, they do not have more suggestions than the canine. Another point on lithium, we before discussed that lithium could be dangerous in terms of kidney, but in this recent meta-analysis published in American Journal of Psychiatry with we did a very interesting point, lithium and pregnancy. Lithium and pregnancy is something that we always are worried. Should we prescribe lithium in patients with pregnancy? No, yes, it's dangerous. Well, the brief answer is that obviously it's a little bit dangerous, but not so much. Not so much. So if a patient is very unstable, it's much worse to keep the patient bipolar than give lithium or any other treatment. Results are here, and therefore if you, I will not go in detail to all of them, but the big message is that the risk for malformation and birth defects is not so high for lithium, particularly after the first trimester. So, this meta-analysis was very well cited and very well accepted because we should not work on myths. Oh, lithium is forbidden in pregnancy. No. Lithium can give some side effects in pregnancy to the child, but we balance things. So avoid first trimester, yes, and of course, if needed, we can give lithium later. And these results support. And these are the classifications, of course. And the last point of this presentation is the future. The future, of course, you know I'm working on genetics, and therefore I'm sure that in a few years we will have targeted prescription based on genetics. We published many things about that, including this very recent paper published on epigenetics on 40,000 bipolar cases. This was published more than 15 years after our previous bipolar analysis. And data is there. There are genes that really influenced bipolar disorder and treatment. And therefore, I'm sure in the future genetics will be of help. We will discuss a little bit this later also, talking about. And the last slide of this presentation is a paper that we just published now, that in the future we will have much more informative trials due to the electronic health records. And so we will have very granular information of millions of subjects. And so what I'm telling you today is nothing about what I can tell you in 5 or 10 years when all this data will come. So we will understand exactly what is happening to every patient. We are introducing electronic health record now in my hospital and in many other hospitals in the country, in every country. And this huge amount of data will be very useful to tailor treatment even more. So in this presentation we have seen that bipolar disorder is a severe disorder that indeed needs treatment. That treatment is difficult both for mania and depression and the maintenance. But one thing is sure and is the basis, that individualization is fundamental. Every patient is different. We have more than 100 compounds, antipsychotics, antidepressants, stabilizer, and combinations. So we must be very careful in what we do because we can indeed improve the wellness of our patients, but we have to work on this. Okay, thank you for your attention. We decided to have a few questions at the end of this presentation. Please.